So first topic is ultrasound guided stellate ganglion block. This block is not new. For long duration, we are using it. Initially, approaches were blind. Even when I started my practice, I started my practice with the blind practice of the ultrastellate ganglion block only. But remember, the area where we give the block is a very sensitive area because there are a number of vessels and that are important vessels going very close to this area. For example, what was the previous technique? An age-old technique is palpating this Shishagnax tubercle, that is C6 tubercle in the hand. So for that, usually first palpate the thyroid cartilage, then go down, go to the cricoid, then come laterally, then come here and palpate the Shishagnax tubercle. Then we have to try to make a space here, and then we have to make sure that we are separating, we are going away, or we are pushing the carotid arteries from our path, and then in between two fingers we are keeping the Shishagnax tubercle, then hitting it, giving the local anesthetic and steroid and coming out. But remember, it was not at all a safe technique because there are a lot of important structures. So we are saying that we have to move the carotid to the lateral side by putting the finger, but sometimes it may not go correctly because we are not seeing. It is not a visualized technique. It was all blind technique. So it might go accidentally into the carotid. Or if you are a little below, or the patient is having some anomaly that instead of C6, vertebral artery is going out. So in this case, the vertebral artery could be also in between this. So ultimately, if you are injecting particulate steroid, or if you are say injecting a non-particulate steroid or a local anesthetic, every time there is a risk that we can cause a vascular injury, we can cause a vascular spasm, and which can ultimately lead to dangerous consequences. So we do not want that. For those, initially when the fluoroscopy came, everyone has shifted to fluoroscopy. But remember, fluoroscopy also is a technique that is slightly better compared with the blind technique, but it doesn't show the vessel even. So under fluoroscopy, the initial technique was the anteroposterior technique that was not much different from the our classic technique. That means our blind technique. Here also from anterior side we used to hit the Shagnax tubercle, but under fluoroscopic guidance. Then we are injecting dye to check whether we are inside the vessel or we are in the longus coli or we are above the longus coli. Here also there is a difficulty because you cannot exactly say whether, because this uh, stellate ganglion is basically situated above the longus coli, and you cannot sure that you are over the longus coli or you are inside the longus coli. So that is not also possible. So there was also some lacunae with the fluoroscopy guided procedures. Okay, so then the technique changed under fluoroscopy. The new technique came up that is known as the oblique technique. Under the oblique technique, just posterior part of the foramen is focused, and just below at the junction of the base of the uncinate process, a little drug at the level of the C6 is injected. So that became the standard technique. But then also you are not seeing the vertebral artery or any artery, and the vascular approach, that means the vascular surety, that is, it is not inside the vessel you are getting, but you are getting after injuring the artery. Okay, not before injuring, because when you are giving the dye, you are seeing that it is going along the vessel, but that time you are already punctured the vessel. So ultrasound in that way actually replaced all those older techniques. In fact, when the ultrasound came, from that time now on, maybe for last 5 years, I have not used the fluoroscopy guided stellate ganglion block because ultrasound gives a good visualization of the nearby structure. It gives a very good view of the vessels. So that's most important. And that is why we can actually directly go into the above the longus coli, either at the level of the C6, or here is the big advantage. We know that stellate ganglion is situated over the body and the transverse process of the C7. But in all older techniques, we have given at the level of the C6 because of the vertebral artery, which sometimes may remain anterior to the stellate ganglion. Okay, so when we are going, we are not able to go at the level of the C7. We used to give at the C6 because of this safety. Because in the C6 level, already artery is under the foramen transversarium. So here comes the big difference. Under ultrasound guidance, if you are getting a good path at the level of the C7, you can go at the level of the C7 and your drug volume drastically reduces. Okay. Whereas at the level of the C6, we usually give around 10 ml of local anesthetic and steroid mixture. Whereas when it comes to the C7, you can just give 5 ml. And that amount of the drug usually good enough to produce you the action. So it's become a big introduction. So let's start with the presentation. So stellate ganglion block used for the complex regional pain syndrome, sometimes for the peripheral vascular disease, Raynaud's disease, or sometimes neuropathic pain, may be sympathetically mediated pain or sympathetically maintained pain. And traditional approach for the stellate ganglion block is the paratracheal C6 Kishagnax tubercle approach, where we used to hit the tubercle, come up a little, and then give the dye or drug. More accurately, it's actually a cervical sympathetic block, because we know stellate ganglion is not present in all persons. Approximately 80%, 85% of the individuals, stellate ganglion remains, and stellate ganglion is basically formed by the fusion of the first thoracic and the lower cervical ganglion. In 15% patients, there are separate lower cervical ganglion and the first thoracic ganglion. So in that case, stellate ganglion may not be present. But as all the structures are remaining in the same plane, though it is not there, if you give the drug at the same plane, it will then go at the level of the T1 as well as at the level of the lower cervical ganglion. So instead of whether irrespective stellate ganglion is present or not, you can actually block the cervical sympathetic chain. Now the question comes, why the cervical sympathetic chain blocking is important? Because it is the main supply, you can say it is from where a number of fibers are going in the upper limb and also in the head and neck supply. So basically the above T1, okay, or above T2, you can say there is no sympathetic outflow. We all know sympathetic is mainly a thoracolumbar outflow. Usually, in most of the cases, T2 to L2, that is the usual outflow for the sympathetic ganglia. Sometimes it can be T1 can also take place. So basically, it is the sympathetic outflow from the T1 and T2 which are designated for the head, neck, and the upper extremities. Through the stellate ganglion, all the fibers are either relaying or they are passing through this ganglion, except one situation, which is known as the nerve of Cones. Again, it's present only in 15% individuals, where some fibers from the sympathetic ganglia directly go to the upper extremity. So that's an exceptional case. Apart from this, in all conditions, they are going through the stellate ganglion. So basically, the advantage of blocking the stellate ganglion is that by blocking the stellate ganglion, we can block the sympathetic supply to the head, neck, and also towards the upper extremity. So what happens if we are having a complex regional pain syndrome, painful condition in the upper extremity, or maybe a Raynaud's disease or a frostbite? By doing a stellate ganglion block, we can cause a sympathetic dilatation. So when sympathetic is actually blocked, then there will be vasodilation, blood flow will increase, as well as when you are having a sympathetically maintained or originated pain, that will also be blocked with this. So that's a big advantage. Now, where does stellate ganglion remains? Stellate ganglion remains in the first step to the transverse process of the C7, not the C6, and close to the vertebral artery and the pleura. Usually, anteriorly lies the vertebral artery as well as lies the pleura. Now, sympathetic innervation from the stellate ganglion, they are the sympathetic innervation to the upper limb. They are also going to the cervical sympathetic trunk and then giving sympathetic fibers to the head and neck. If you block it, it will cause vasodilatation. So all vasospastic diseases that is causing pain, that can give pain relief. Also, after blocking, if there is any sympathetically afferent mediated pain, that will also be blocked, as well as there will be decreased sympathetic tone. So main indications for this block are two types. One is the pain related issues, for example, a complex regional pain syndrome we are discussing again and again, or in case of any condition which is affecting, for example, a Burgess disease, or example, a Raynaud's disease, or example, a frostbite. So that is causing vasoconstriction can be treated with the stellate ganglion block. Now, I have already told about the existing techniques in the introduction. So you can see here it is a technique that is a mainly anterior-posterior technique or a comparatively older technique of fluoroscopy guided approach. But still you can say here we have to rely on the dye or the contrast agent to find out whether we are inside the vessel or not, and we can only guess to find out that we are inside the vessel or not when we are already inside the vessel. So fluoroscopic iodide actually given a little solution, but that was not enough. So it has limitation that it can actually cause vertebral artery injury. There are chances we can accidentally go into the esophagus, which may occur in approximately 53% of cases, and there are risk of hematomas if you are actually going and just puncturing any artery, for example, carotid or vertebral. So that problem was there with the existing techniques. Now, when the ultrasound came, it's a real-time visualization of the vessels, nerves, esophagus, thyroid, longus coli, and reduces risks of the vascular puncture, esophageal injury, as well as of the hematoma. Now, it's the most important thing. What is the sonoanatomy? But before going to the sonoanatomy, let me discuss a little bit of the anatomy. I will not be going into much detail of the anatomy, but in short, I will try to enlighten you a little bit on the anatomy. Okay. So here I am opening the anatomy, and I am opening with all structures. With all structures, initially it's a little difficult to appreciate the exact structure, but this is what we can see under the fluoroscopy, or sorry, under the ultrasound, because we cannot see specific structure. The small superficial vessels are usually hidden because of the pressure. If you give a little pressure, that will be blanched. So what structures we are seeing here? This is one muscle. This is known as the sternocleidomastoid muscle. So this is one of the important anatomical landmark for the stellate ganglion block. So let me hide for now the this ganglion. Then we are actually hiding the lymphatics. Then we have two important vessels. This is the internal jugular vein and the carotid artery, as well as we are having the thyroid gland at this point. So let us hide those structures to find out the inner core, what we are having. Okay. So here, if you go close to the vertebral body, okay, I am hiding a little bit of muscles. Okay. Then we'll see this is the vertebral artery, and it at the level of the C6, it is going inside the foramen transversarium of the C6. So where lies the stellate ganglion? Stellate ganglion lies somewhere here. That means at this point, let us hide the superficial vein as well. So this is the C7. So from C7 and T1 at this area remains the stellate ganglion. So under ultrasound, here we'll be able to see the sternocleidomastoid, we'll be able to see the carotid, as well as we'll be able to see the longus coli muscle that I have hidden to show you the inner structures, as well as we'll be seeing the nearby muscles as well. So let's go for the ultrasound demonstration, that what we can see under ultrasound. Okay, let's go again to the presentation. So under ultrasound, what we see is this. This is the transverse process. Then this is the anterior tubercle of the C6. This is the internal jugular vein. This is the carotid artery. Here we have the longus coli muscle. And remember, this longus coli is our target. So we can see important structures like sternocleidomastoid. We can see the vertebral body. Then we can see the longus coli. We can see the carotid artery. We can see the internal jugular vein, and we can see the tubercle. Basically, this anterior and posterior tubercle of the C6 level is very important for identifying the level, because at the C6 level, this Cachagnac tubercle is actually anterior tubercle, which is a higher tubercle than the posterior tubercle, or sometimes it may be of equal size. But in other levels, because when we go to the C7, you will see anterior tubercle is in those cases rudimentary, and only the posterior tubercle is seen clearly. Now, where remains the stellate ganglion? So you can see this carotid artery and this internal jugular vein. remain. They are covered by a fascial sheath, which is known as the carotid sheath. Now, posterior to this, we are having the longus colli, and just above the longus colli, we are having another fascia that is known as the prevertebral fascia. So those who have already forgotten, I think all, or not all, but many of you have forgotten the cervical fascias. So let's look back a little on the cervical fascias. So what fascias we are having at the cervical area? The first fascia is not shown here, but the muscle content within the fascia is shown here is this one. This is the platysma, this black line where I am putting the needle. This is the platysma muscle, and this is the superficial fascia. This contains the platysma at the cervical area. Now, if you look at the deep fascia has multiple layers. This layer is known as the investing layer of the deep cervical fascia. This fascia encases two important muscles from anteriorly. It is the this muscle. Can anyone tell what is the name of this muscle? Where my cursor is? Please, anyone from you? Sternocleidomastoid. From posterior side, and someone else from posterior side. What is this muscle?
Trapezius.
Trapezius. Yes. So, investing layer of deep cervical fascia encases these two important muscles. Then we have the prevertebral layer of the fascia that is actually taking or covering this inner neural structures, including the vertebra, as well as the deep muscles, including the scalenes here and longus colli at this point. Okay, so this is the deep fascia, and here you can see the sympathetic ganglion, but under ultrasound it is very difficult to differentiate the sympathetic nerves here. So basically what we'll be able to see is the fascia covering the longus colli. Sorry, not this one, this one. Okay, here at this point it will be, and as I show, it is not normally seen. Okay, so it is not, these neural structures are mainly from the brachial plexus. Thus at this point remains the sympathetic ganglion here. Okay, and this area covering is, this is the carotid sheath. Then here we are having the pretracheal layer, and here posteriorly this yellow one is the buccopharyngeal fascia, and this layer, the anterior layer of the prevertebral fascia, which remains partially over the longus colli, this is known as the alar fascia. Basically when we are going, we have to go somehow negotiating in between this carotid area, and ultimately we have to reach to this point. That means the anterior portion of the longus colli at the level of the C6 or C7. Still today, in a number of cases, C7 sometimes becomes a little difficult because of the location of the vertebral and carotid artery. So most of the cases still today we have to go at the level of the C6 because it is definitely safer from our previous experiences, and we can give over the longus colli. Ideal location, it is stated that it should be given deep to the prevertebral fossa and above the fascia covering the longus colli, but in practical saying it is not possible. So only thing you will be not be doing, no, don't go inside too much inside the longus colli. At just above the longus colli, just inject it. So let us discuss the technique step by step. First, the position. Patient position is supine with the neck extended. Then put a high frequency probe at the level of the C6. Identify carotid, longus colli, transverse process. Then from the lateral approach, take your needle, enter, just go over the prevertebral fascia, avoid vessels with the Doppler, or sometimes the movement of the vessels is also seen. Inject 5 to 10 ml of local anesthetic under the real-time imaging. In fact, if you are injecting at the C7 level, then you can inject very small volume. 3 to 5 ml is good enough, and if you are going at the level of the C6, usually you can go something between 7 to 10 ml of the drug. So this structure you can see here. This is the carotid artery. This is the longus colli. This is the anterior tubercle, and here is the needle going just above and injecting just above the longus colli muscle. Okay, don't go deep inside the longus colli. So let's start in clinical parts. Pre-scan is essential to detect the esophageal deviation, or subfascial injection is better because it can cause a caudal spill. If you are too deep into the longus colli, it may be ineffective. real-time monitoring prevents the intravascular injection definitely, but this procedure is not complication-free. There are chances of the intravascular injection and resulting complications. There could be esophageal injury, might causing mediastinitis. So accidentally, if you have injured the mediastinum, at least given little antibiotic prophylaxis. First of all, do not do that. Then, if accidentally done, if there is a retropharyngeal hematoma that can compromise the airway, that could be dangerous. So you have to, if you have accidentally done puncture here, so give pressure first. Don't worry, the other side will preserve the circulation to the brain, and give cold compression. So that, and most important thing is that is ignored sometimes by the pain physicians because of the office based procedures, always do BT CT PT before. Okay, so that make sure that the patient's coagulation profile is absolutely normal, then only you can go in a risk free way. And sometimes there could be hoarseness of voice, but we are not bothered about it because it is very short duration. Now another question is the Horner syndrome. Is Horner syndrome a complication of it? Can anyone tell?
It's not complication, it's a consequences.
Yes, Horner syndrome is the consequence. That means it is the sign of a successful block. It is not the complication. So can anyone please enumerate the features of a Horner syndrome?
Ptosis, meiosis, and hydrosis.
Okay, and loss of ciliospinal reflex.
Reflex.
So these are the common things that might happen. So commonly we check with the light, nowadays commonly with the mobile torch. Okay, check the pupillary dilatation difference in both the levels. Okay, and meiosis will be clearly observable. And then also in the hand you might get increased blood supply because of the sympathetic blockage. So there might be actually heat in the hand, and also the pain relief for which the patient has came for us actually. Now, what is the conclusion? Ultrasound guidance improves accuracy, safety, efficacy, no doubt, 100%. Reduces risk of vascular and the visceral injury, 100%. Provides real-time monitoring, 100%. And now considered standard care for the stellate ganglion block. True. Last 5 years, I have not done anyone with the fluoroscopy. So that was all in the theoretical part. Let me, no, not all, because we have other topics as well. But for the stellate ganglion block, the theoretical part is over. Let me show on the volunteer. So how we will be going for it. Okay, I'm switching off from here and okay, hopefully everything is visible now. So this is the head end. This is the head end. Okay, I'm coming here. This is the head end. This is the tail end. Okay, out of the chest, towards the chest. So let's start scanning. So first the surface landmarks. So here we can see we have the thyroid cartilage, then we are having the cricoid cartilage, then we are going just by the side and we have to find out the Schischek-Nax tubercle. So let's see. After we have located where it is, we are going for the scanning. So usually for all patients, I first go for the surface landmarks because it is very easy to find out those structures. Now, let's go for the scanning. So we are keeping the index marker towards the medial side. So that towards the left side of your screen will be medial side, and towards the right side of your screen will be the lateral side. Okay, it is not visible. Just 1 second. Okay, now it came. Now you can see it. So here at this point, when we are looking at two big vessels can easily be seen. One big vessel, and just by the side, we are having one artery. So I do not know at which level I am, but I am just seeing a little bit of thyroid tissue at this point in the left side, okay, left side of the screen. Then we have the carotid, and then in the right side, we have the vein, but vein is having a wavy pulsation, whereas the carotid is having a arterial pulsation. And above, we can see a little bit of strap muscles. So it is very difficult to comment if I do not localize. It is the sternothyroid or sternohyoid. So both they can be. So here is the strap muscle, and then we have the sternocleidomastoid. So sternocleidomastoid is a long and large muscle. Now add the picture just below the yellow dot. Can you observe some bony prominence? Can anyone tell what is this? Okay, let me stop. So what is this bony prominence? This bony prominence. Can everyone see my cursor?
Yes, yes.
So what is this bony prominence?
C6 tubercle?
Yes, this is the C6 tubercle or Sessegnax tubercle. And just by the side, we have the muscle. So what is this muscle? Is it visible, the muscle? Or I need to draw.
Longus colli.
Longus colli.
This is the longus colli muscle. So for this patient, you see how the beautiful path is there. So for this patient, it will not be difficult. We can choose the C6 level because no important vessels are in between actually obstructing us for giving a good block. So we can take our needle sometimes by the side or sometimes even puncturing, because muscular puncture is not a big issue, and just we have to go through that, and we can easily come from, just 1 second, lateral to medial side, and we will be coming over this structure. Okay, so now we are over the longus colli. So we can inject beautifully here. So for this patient, this much we can solve easily, but for our knowledge, we need to learn a little more. So we'll be seeing the structures a little above and a little below as well. So let's go below first, because we need to see the vertebral artery, because we need to know that which structure I should not puncture. Okay. So as from this area, okay, sorry. Now the orientation changed because accidentally I hold the probe in the opposite direction. So here at this point, we see the two tubercles of the C6. Okay, and here the nerve root is actually coming from within. Now we are going down. As we are going down, C6, মাথাটা ঠিক হয়নি আজকে একটুখানি নিচে। Okay, so we need an extended head. For the C6 it was fine, we are able to see easily, but if you go at the lower level, now see, from here it was good, we can see the C6. Now once as we are going down the C6, then another artery starts appearing into our view. Okay, so if we give color, okay, so let us reduce the gain. Okay, now we can see the vertebral artery into our view. Okay, so when we are going above at the level of the C6, see, vertebral artery is within that foramen transversalium. So here we do not have any major important structure except for this artery. Okay, let us reduce the gain. Okay, so here is the artery, we can see, and just by the side we have the vein. So when we are compressing it, it is not with only longus colli is visible. So basically here we can go easily at the level of the C6, but as we come down, here comes the vertebral artery. Okay, so we should not puncture here the vertebral artery, and as we will go down, then we will be able to see একটুখানি মাথাটা হচ্ছে না এই এরকম okay. Now we are at the lower level. So here you can see the C7. Okay. So C7 only we can see the posterior tubercle, anterior tubercle is not seen. So here lies the posterior tubercle of it. Scribble. Okay. So here lies the posterior tubercle of it. We are not able to see the anterior tubercle. Okay. And here, if you give color, we will be able to see the artery. Okay. Okay. Now here we can see at the level of the C6. Okay. So understood this part? This is the C7 part with the vertebral artery, and this is the C6 part with the tubercle. Okay. So that was the theoretical part. Anything else you want to know in this regarding stellate ganglion?
Sir, I have one question. If we approach from lateral side, is there any chance for jugular vein damage?
See, jugular vein damage chances are not there. It is not right. It is there. But in most of the cases, what happens, as it is a vein and we are checking the coagulation profile, so even if you puncture the jugular vein, it doesn't cause any big complication. We always try to avoid. So while putting the drug, you just release the pressure over the while injecting the making your trajectory. That is the most important. While you are selecting your trajectory, at that time release the pressure, try to avoid injuring it. But sometimes it is not possible. I am telling you, it in practical, it doesn't happen that every time it is not injured. Sometimes it is blanched and your needle passes through it, but it doesn't usually cause a lot of complication. Okay, but we always should try to avoid this. Any other question?
Volume, sir? How much volume?
I have already told, if you are going at the level of the C7, if you are getting a good view at the level of the C7 and you are doing along the C7, usually 3 to 5 ml is good enough at the C7 level. And if you are going at the C6 level, usually in between 5 to 10 cc.
So one question from my side.
Yes.
So any chances of the phrenic nerve block there? Phrenic
Yes.
nerve.
Yes. Accidentally, drug might spill over to the splenic nerve as well. That is why it is very rare to do a bilateral stellate ganglion block. There is only one indication that the pulmonary thromboembolism, but even for pulmonary thromboembolism nowadays, no one take that risk of blocking in both sides.
Yes. Both side is not allowed.
Yes.
Thank you.
So
I
in
told you, there is
ultrasound,
a theoretical indication that is a
Yeah.
pulmonary thromboembolism, but even it is not a practical thing nowadays.
Sir,
we can visualize the phrenic nerve, sir, at that level C6 or 7.
At the level of the C6 phrenic, the visualization of phrenic nerve is possible, but it is not always clearly visible. When doing in different patients, if the patient is lean and thin, you can see most of the structures more clearly. But in real patients, if the patient is heavy, short neck, seeing it becomes very difficult.
sir,
Thank you.
Yes.
sir, which drug is used?
Okay, so commonly used drug here is the local anesthetic with steroid, and here
Sir,
under
Dexon.
ultrasound, now even today we are using the particulate steroid only, though if you want you can replace with a soluble steroid. Okay, here even today I use the dipomethylprednisolone or triamcinolone only, but definitely there are some guidelines that say that the soluble steroid is better. So it is not that I have not used the soluble steroid. So I have also used the soluble steroid, but as a common practice going on years, I sometimes continue with the previous one. But definitely you can use a soluble steroid for enhanced safety.
The volume is same for every
Volume
steroid.
is same. Okay. And if you are giving dexamethasone, you have to give 8 milligram dexamethasone here.
Okay, sir. Thank you, sir.
Sir, what about the thyroid arteries?
Yes, it may come. Remember, the small arteries are visible, then you try to avoid it. Okay. In most of the cases, if they are visible, and when you are selecting the path, okay, you check with the Doppler and check your path. You make sure that you are not injuring any artery. Remember, we have done blind, and that time we do not know how many arteries we have punctured. So those days are over. So nowadays we actually go by seeing any vascular structure. It is not any specific artery. So switch on your Doppler, check if any arteries is there or not, and go just over the longusculi. Okay. Chilmada, you start with the CRPS. So let's start with the theoretical, two theoretical topics. One is the CRPS, and then we'll be switching over to the other topic, that is the myofascial pain, and then we'll be going for the fibromyalgia.
Okay. So actually these topics are theoretical topics, so you may not get that much interest, but these are very important topics because these patients, though they are treated by different specialties, but ultimately the treatment, if we compare, the best treatment is probably given by the pain physician only. So CRPS, what is the full form of CRPS? This is the complex regional pain syndrome. Now, identify these cases. Okay, so here you can see this is two hands on patients, and you can see there is some differences there. This is a normal hand, but here you can see the cracking of skins. Okay, that these nails are bigger. These nails are longer. Okay, and here in the, if you compare the foot, then one side you see a bit pink or bluish discoloration is there on the skin. Another side is normal. Here there is some small amount of edema is there in the leg, and sometimes this edema is not even perceived by the by the doctor, but then this patient can say that my foot is a bit swollen. So here, of course, we also can see that this is red discoloration, and there is some swelling is there. Okay, so here this specific type of cases, mainly you can see from here, we can see that extremities are involved. Most commonly extremities are involved, and this type of picture can come, with this type of picture, patient can come to your clinic. Patient will complain of burning pain, loss of sweating, dry skin or glistening skin, and edema. Edema may be subjective edema. It may not be objectively understood by another person. Then color change. Color change is also very common. Okay. So here, this type of patient, one patient came to me long back, of course. So he consulted nearly 16 doctors, and his hand was, otherwise it looks normal only. Only thing is it was dirty. Like he never allowed anyone to touch. He did not take bath whenever he used to, bathe. Then he made it sure that at least water should not touch his hand. So it became dirty gradually, and it will be always remaining in this type of position. So, and what he consulted 16 doctors. So what they did, so many people, they did some investigations, of course. Then investigations were normal. NCB could not be done due to severe pain, but people had advised NCB. Okay, but it is if the patient doesn't even allow the liquid or water to touch his hand, he will not allow to do the NCB. I mean, no one can do the NCB. So this was obvious. And then conservative treatment failed. So, I mean, a very high dose of amitriptyline, gabapentin, all was given to this boy. Then physiotherapy, it was also advised. But whenever he goes to the physiotherapist, it was not possible due to the pain. So this is a common scenario. And here only one thing is not common, that he is a very young boy. Usually it is a mid-aged woman. Okay, so that is more common. Now, motive behind history taking, when we will take the history, so in this type of presentation, then what actually we want to know? First thing, where from the pain is coming, means pain generator, and type of pain and pathophysiology behind. So these three questions are common for all types of pain. Now, there are multiple these scales are there for understanding the type of pain, nociceptive, neuropathic, or nociplastic. So different which type of pain patient has. So these are neuropathic pain questionnaires actually. So whether I mean, I'm not going in detail. Just remember allodynia and hyperalgesia. So as you can see that this patient do not allow anyone to touch. That means he has allodynia, and hyperalgesia was also there. I mean, of course, you cannot pinch this type of patient, but if someone pinch, I mean, puts a needle prick or just pinch also, then patient will scream with pain. So while taking history, we will first see that where from pain is coming, why it is becoming painful, and what is the type of pain. So one thing is very much sure in this case, that this is a neuropathic pain by the characteristics, allodynia, hyperalgesia, and otherwise color change, vasomotor change, all these things were there. Okay, now this thing also we will keep in our mind, that whether there is any chance of fracture, infection, malignancy, or motor weakness, because these are red flag signs. So in differentials, we will always try to make a pinpoint diagnosis which is treatable. There is no point in making a diagnosis of CRPS I mean, it is not a positive point when you are thinking of treatment. CRPS is very difficult to treat. So first, always try to make a known diagnosis with a known treatment, that maybe that patient is this patient. Okay, so you can see all these things are possible: radiculopathy, plexopathy, neuropathy. But then these are all differential diagnosis. The presentation which I told you actually doesn't match completely with all these differentials, and we can easily identify that okay, this is a patient of CRPS. Sometimes actually neuropathy, for say diabetic neuropathy, or the peripheral small fiber neuropathy. So in those cases, you can get confused. But still, if one side is affected and there is a precipitating factor and gradual increase, then you know that this is a neuropathic pain and this is CRPS and not due to diabetes. Now workup. So workup, why this workup is done? So our intention is two intention. One, exclude the known diagnosis. If it fits with any known diagnosis, then well and good for the patient also and for the doctor also, because the treatment will become easier. So first thing, we want to see that if it matches with any, it gives a corroborative evidence for any other diagnosis. And second thing is, if it gives any indirect evidence of CRPS. Otherwise, CRPS do not have a direct evidence. Okay, there is no investigation which can say that directly that it is a case of CRPS. So what we will do, first we will do the blood tests. So simple blood test like complete blood count and say ESR, CRP, liver function test, kidney renal function test. So all those things just to exclude the any comorbidity. Then if possible NCB, but most of the time it is not possible. This is to see the sensory neuropathy, not sensory, I mean sensory motor neuropathy in the diabetic cases, at least to exclude. Then comes vascular studies. Doppler you can do if there is a specific case of bluish discoloration of the hand, then you should see that whether blood supply is all right or not. So these are initial investigations. Then plain radiographs. What do we want to see in a specific case of, say, it is a joint related, if there was a Colles fracture in the, or any wrist fracture, and then patient had a has developed CRPS of the upper limb. So it usually shows a small area of osteoporosis may reveal endosteal or intracortical excavation, resorption of subperiosteal or trabecular bone, localized bone demineralization, or osteoporosis. So this is actually a indirect evidence of CRPS. Okay, so as I told you, first exclude other diagnosis, then you search for some indirect evidence. So here, after, if you find this in radiograph, then it is a very advanced stage. But if you do not find, you can go for three-phase bone scintigraphy. In this three-phase bone scintigraphy also you can find the same thing, this osteoporosis or higher uptake of these areas where the affected area by CRPS. Pulse oximetry, what it will see? So the blood supply, it can be less or it can be more. Most of the time it is less. So you will see the pulse oximetry, the plethysmograph has become less in one side. If you compare with the, if say opposite hand is all right, so you will see that one hand plethysmography shows that much less blood supply. And this pulse oximetry has a role while you are doing a stellate ganglion block or doing a treatment, because with the if your block has gone in the right place, then within 2-3 minutes you will see that plethysmographic graph has increased. That means you have blocked the sympathetic supply in the correct way. Okay, now temperature also, usually there is a 2.5 degree Fahrenheit, 2.5 degree Fahrenheit temperature difference between two limbs if one limb is affected. It is a minimum. More also, there can be more difference also. Then comes MRI. So MRI also shows the osteoporosis area. QST, quantitative sensory testing. Actually, nerve, when we are seeing the NCB, we are not seeing the small fibers which carry the pain. We are seeing large fibers. So large fibers we are carrying, which is carrying the vibration and also though sensory modality, but not pain. So by quantitative sensory testing, we can see different fibers. NCB is together investigating the sensory fibers, but then with QST you can see directly different fibers. So that investigation also can be done, but usually done in a experimental setup. Autonomic function testing, like how much sweating is going on, it is less or more if you compare with the opposite side. Biopsy, lastly, which biopsy? Skin biopsy. Skin biopsy you can do if there is a change in the findings. Okay, the nerve fibers, density of nerve fiber changes. So ultimately our aim, first exclude the other differential DD and find some indirect evidence of diagnosis for CRPS. Okay, so same thing, exclusion. This is a exclusion diagnosis. Remember, earlier this type of patient used to go to the doctor and then doctor will become totally confused that what to write in the diagnosis. It doesn't match with anything. So ultimately, they could not write a diagnosis and treatment was also not standardized. Okay, so here it is the exclusion diagnosis, history and physical examination. Of course, we have to do in every patient. So here we have to see mainly the musculoskeletal system and neurological system. Neurological patients are intact or not, whether there is any deficit of the sensory or motor system, that we have to see. Then comes here investigations are adjunct. So from investigation we do not actually get too much thing. Okay. So here, see, as I told you earlier, when patient used to go to the doctor, then there are so many diagnoses. Okay, RSD, causalgia, algodystrophy, shoulder hand syndrome, suicide disease. There are many other names are there. I have not mentioned here all the names. So these are all the description of the same disease actually. Okay. Then in 1994, many criteria came actually to diagnose, to standardize the diagnosis as well as the treatment. So these are the IASP criteria came in 1994, then Bruehl's criteria, Veldman's criteria. So many people used a bit of modification and then they gave the criteria. But ultimately Budapest criteria became very popular in 2003. So just remember what is there in Budapest criteria. So Budapest criteria can be divided in 4 parts. One is sensory symptom or sign, sensory symptom or sign, motor symptom or sign, vasomotor symptom or sign, and pseudomotor symptom or sign. So what are there in these parts? So sensory can be allodynia, hyperalgesia, first 2 things. Vasomotor means blood supply related. So either it is a temperature asymmetry. If blood supply becomes more, temperature goes up, or blood supply goes down and temperature goes down. Same case with the color change also. So vasomotor means temperature related. So temperature asymmetry and skin color changes and or skin color asymmetry. So you can understand if it is pinkish discoloration or bluish discoloration. Okay, temperature high or more. Then pseudomotor or edema. So edema, as I told you, it can be not objective edema, it can be subjective edema or sweating changes and or sweating asymmetry. So with sympathetic supply, if it is a sympathetically mediated pain, then patient can have more or less sweating also. Then comes motor or trophic. So these changes are not there in were not there in every patient. This will come as per the stage. So decreased range of motion and or motor dysfunction, and that will gradually lead to the trophic changes. Even the hair and nail and skin, there are changes. As I showed you the picture, the nail was bigger. So otherwise I mean, like even the hair of the extremity also can be different, it can be less. Okay, so these changes come gradually mainly due to disuse of that limb causes a atrophy of the muscles. Okay, so anyway, if you find that at least one sign or 2 or more of the categories, then you know that at least one sign in 2 categories, and at least one symptom in 3 categories, and mainly as I told you, exclude other diagnosis. That is first thing, exclude other diagnosis, and it should be too much painful. So these are the criteria for diagnosing. So here you see it looks nearly same. Okay, so every patient will not come to you with the similar stage. Some will be very early stage, some will be very late stage. So this patient is in an early stage, but allodynia, hyperalgesia was there in this side. This side is normal actually, this side is glistening and this side was a bit edematous. Okay, this was normal. So anyway, this patient, this was a very less affected, you can say, from outside, and here you can say it is severely affected. Leg is swollen, here bilateral, both leg are having the CRPS, and whenever sympathetic system is affected, so this is very common, both side gets affected. It starts from one side and it goes to the opposite side also, and in hand this side is affected. Okay, so this patient also came to me. Here patient I mean many neurologists actually, they just advise that go to physiotherapy and you have to do physiotherapy. So patient went to physiotherapy, and during physiotherapy they broke her one finger. So this can also happen. And when she came to me, her hand was like this. You cannot make even one centimeter space also between palm and the tip of the fingers. And when she went after 6-7 days of stellate ganglion injection and treatment, so she went like this. After actually I lost the patient in follow-up, but at least this much was there. Comparison of CRPS. So two types of CRPS, 1 and 2. This is actually not important to divide in CRPS 1 and 2. So here remember, 1 and 2 means 1 means without any known nerve injury, and 2 means with known nerve injury. Means precipitating event or single peripheral nerve involvement. In CRPS 2, it is very known, like someone has wrist fracture, someone has some some other shoulder fracture. So that patient has developed CRPS, you know that nerve got affected. And some patient was just like that, did not happen anything. So then we will say it is CRPS 1. Now, why this distinction was done? Because it has been seen that CRPS 1, which develops without any reason, so it is progressive, bone atrophy occurs, and it becomes severe. But if there is a precipitating region, then prognosis is better compared to the one. So this is the use of this classification. At least you can say to the patient, if there is a precipitating factor, that you will become all right, don't think. So these are stages: acute stage, dystrophic stage, atrophic stage. So you can simply understand, when patient goes to the atrophic stage, it is very difficult to reverse. But if it is in the acute stage or dystrophic stage, then it is easy to reverse. CRPS NOS, what is that? So this was recommended in different books, and then gradually it has been accepted also. So CRPS not otherwise specified means NOS means it is not that, as I showed you some picture, that it is not fully developed, very less sign symptom. In those cases also, if we do not write the diagnosis of CRPS, then treatment cannot be justified for CRPS. So, and then those patients will not be taken into account for treatment. So, understanding that sometimes these patients are developing CRPS stage, in a developing CRPS stage. So then also we can write CRPS NOS, means no other diagnosis, not otherwise specified. So no other diagnosis can be matched. So it is a developing CRPS. That is meant by CRPS NOS, and we can start the treatment. Of course, the prognosis will be much better in these cases. So in pathophysiology, just remember, it is sensitization. Any neuropathic pain, this is the keyword. I'm not going in detail of sensitization, because that we read in physiology, first class physiology. Okay, so this what happens is sensitization. And sympathetically mediated pain. So remember, sympathetically mediated pain in CRPS, it can be, it cannot be. I mean, it can be present or it is absent. Two things can happen. I mean, like it is not that always in all CRPS cases are sympathetically mediated pain. It may not be present. Now, so this sympathetically mediated pain, if it is there, that is the basis of our treatment, or say stellate ganglion block, just you saw. So that is the basis of upper limb CRPS treatment by stellate ganglion block, because if we can prove that it is a sympathetically mediated pain. So a new hypothesis, there are multiple hypotheses. So multiple hypotheses has come gradually. So it is a some paper have told that it is nothing but a small fiber neuropathy. So as I told you, in differential diagnosis, sometimes with small fiber neuropathy, like diabetic small fiber neuropathy, you can confuse. Treatment, oral medicine, intervention, TCA, anti-epileptic are the oral medicines. So many patients will come to you after the neurologists have seen, or say other people have seen. So they will always start the TCA or anti-epileptic like gabapentin, pregabalin, and then patient will come to you. So you will get in this stage. Otherwise, if the patient is a fresh patient, then of course you can start with these medicines. So these are first step. Second step is intervention. So intervention is sympathetic block. Sympathetic block means, so if upper limb, we will target stellate ganglion. If lower limb, we will target the lumbar sympathetic. But of course, after block, we have to first prove that our block is correct. How will you prove? So with pulse oximeter, we can prove, and with some other sign symptoms also we can prove by seeing with ultrasound, directly putting the needle under view. We can prove that our procedure is correct. After that, whether patient's pain is gone or not, that depends on that whether that CRPS is CRPS pain is sympathetically mediated pain or not. If positive, then only you can go for a long-term treatment like radio frequency or some kind of neurolysis of that still sympathetic ganglion. If it is negative, that you can see that okay, pulse oximeter is showing that okay, vascularity have increased, but still patient is saying there is no difference in pain, then you will not go for a definitive treatment. So approach, so this is common thing in pain, multidisciplinary approach, multi-model approach. So you can try all approaches. And of course, we always take help of physiotherapy and psychiatry. Psychiatry, yeah, patient is sometimes very depressed, so some psychological help is needed. And physiotherapist is always needed because after giving the stellate ganglion block, as the patient's pain has decreased, then you have to send to the physiotherapy for starting physiotherapy for say 2 hours, 3 hours till the pain relief remains. Again, pain will come. Patient cannot do physiotherapy. Again, next day patient will come. You gave the stellate ganglion block and send to the physiotherapy. He will do the physiotherapy. Guided physiotherapy again. So in this way, if you can continue for 5, 6 days, 7 days, patient becomes all right. Anyway, so. So aim of treatment, mainly pain relief, functional restoration, psychological support. These three things are our aim, and mainly prevent the onset of irreversible stage 3. So that is the functional restoration. Okay, and you treat early. Treat early, you know how to understand the prognosis also. If there is no precipitating factor, prognosis is not good, so you cannot waste time. Okay, and then rehabilitation, so physiotherapy, vocational rehabilitation, recreational therapy, all these things have some role. If your hospital has or you know someone that who can give their part, you always take help of those doctors or those specialties also, because ultimately this is a very tough disease to treat. So it is better to go for a multidisciplinary treatment. Intervention, sympathetic block. So you can understand this is C7. So we can see that C7 nerve root, vertebral artery. This is the longus colli muscle, and stellate ganglion is here. Here or here doesn't matter. It is just under the capsule of the longus colli. And this is C6 area. So most books recommend inject at the C6 area, but you can go at the C7 area also, because otherwise also, if you say diagnostic block is positive and now you want to go for RF, then you have to go at the C7 level. Then you cannot do anything at the C6 level, because stellate ganglion lies at the in front of C7 T1 disc. When all modalities fail, then of course you have only two option, that is the spinal cord stimulator and intrathecal pump. So that is very bad condition. This is a continuous stellate ganglion block we did long back. This was his hand severely affected. Continuous stellate ganglion block, and pregabalin and pregabalin was going on. Some other drugs also was going on. So the patient became much better. I will not say completely all right, and then I didn't follow up, of course. This patient, so this is the young boy. Now he has become all right after giving injection, diagnostic. Then I did radiofrequency ablation of the stellate ganglion under X-ray. Under X-ray, I did the ablation. I did not try under ultrasound. So this patient was, but this patient I did multiple times, because he came every 8-9 months or 1 year, and I did the procedure 2-3 times, 3 times maybe, and now he is all right. Now I know him that he is all right. So there are multiple other modalities like PNS, peripheral nerve stimulator. So this type of peripheral nerve stimulator people have placed. So many people did amputation also, but this is very bad. Nobody should do amputation for CRPS. Anyway, so these are literature search findings. I'm not going in detail. Only important thing is that we know CRPS of hand or leg extremities, but it is not always, I mean, you cannot say that 100% CRPS are in the extremities only. Abdominal wall CRPS, that also we saw. And then lumbar herniated, I mean, this is lower back CRPS. So this has been reported. I myself have seen that CRPS of shoulder, back of the shoulder, and CRPF of thighs. I have seen CRPS of thighs, and treatment is same. If something is lower limb, you will go for this one, lumbar sympathetic block, and upper limb stellate ganglion block. Maximum you can go to T1, T2, T2, T3, T2, T3 sympathetic block. So that is the treatment. But these are not that much common. Okay, so here conclusion is like treat early so that patient doesn't develop a irreversible stage. Any question here?
Sir, what happens to the acute phase reactants in CRPS?
What?
What happens to the acute phase reactant levels in CRPS, like ESR, CRP, as those
No. These are all nothing, all normal, all blood test normal. This ESR CRP is a systemic inflammatory marker. Nothing happens in systemic. So these are all local thing. I mean, in blood test, everything normal. And microscopically, if someone does the biopsy and all, let's say, experimental thing, then we will of course see the cytokine is increased and all. But in blood test, all normal. And that is why mainly I told you exclusion diagnosis, you cannot match with any other thing. But this is common, and our treatment is the best treatment. Nobody else has any option to treat these patients. Myofacial pain syndrome. So this is commonly done, treated by many people, not only us. It will be treated by physiotherapy, sports medicine, everyone actually. So you can see myofacial pain syndrome that can occur in different muscles. mainly trapezius. You can see these are the some common areas are there. It is not you will not see a myofascial pain syndrome of deltoid muscle, not deltoid. I mean biceps muscle. So you will see these muscles are common: trapezius, rhomboids. Okay, then lower back paraspinal muscles. So these are common areas. Okay, mainly the suboccipital area, suboccipital or paraspinal area in the cervical spine. So these are very common areas for developing myofascial pain syndrome. And nowadays people work in front of screen for a long time. So this is very common. Trigger points are hallmark signs of myofascial pain syndrome. So we have to search for a trigger point. And remember, ultimately, where do we confuse? When a patient comes to us, where is the confusing point? Point is with radiculopathy. Whether, say, one patient is saying my pain is in the shoulders. So you always have to think that whether there is a C5 radiculopathy or C4 radiculopathy. So you have to change. I mean, at least you have to examine in such a way that you can differentiate that it is not a radicular pain. Okay. So what are the trigger points? So trigger points are focal knots located in a taut band of skeletal muscle. So patient can say that this is paining, this is paining. So you just put your tip of your finger. It is not like palpating. Tip of your finger on that point, and patient will winch. Like patient will say that yes, this is the point. Okay. So maybe formed by acute trauma or by repeated micro trauma, leading to stress on muscle fibers. So here, this is the area. So these focal knots are mainly called as trigger points, and this is the hallmark. Okay. How to identify? So as I told you, local twitch response. If you just hit with your or press with your tip of your finger, you may see, and while doing dry needling or needling with for treatment, trigger point injection, then also when your needle tip touches inside that taut band, you may see a small twitch like phenomena. Okay, multiple times it will not come. If you try multiple times, it comes at the first time only. So at that time you must see that whether this twitch has come or not. It causes pain, stiffness, and decreased range of motion. So this is common with the muscle spasm. May be associated with chronic disorder of musculoskeletal pain, musculoskeletal system. So I have seen many Parkinsonism patients that may develop this type of pain. Not a tender point. So tender point are common in fibromyalgia, and trigger points are hallmark in myofascial pain syndrome. What is the difference? Trigger point, when you press it, pain is a referred pain. It goes somewhere, not too much distance, but say 2-3 centimeter, 2-3 inches it goes. Okay, it refers, and you see the local twitch response. But when it is fibromyalgia and it is a tender point, then pain is there only, and pain is pain is not going anywhere. Okay, and otherwise, of course, fibromyalgia trigger points are there everywhere in the whole body, right side, left side, upper half, lower half. But in trigger points, it is a myofascial pain, and specific group of muscles are involved, not the opposite side, not at a distance. Okay, so these are tender point, not a tender point. The most common muscle groups are masseter, levator scapulae, gluteus medius, quadratus lumborum, trapezius, sternocleidomastoid, and temporalis muscles. Okay, trigger points affecting the trapezius muscle may clinically manifest as tension, headache, pain in the neck, shoulders, and proximal arms. So remember, nowadays in pain clinic, these group of patients are a major chunk of patients because of IT sector. I mean, or say computer in our work, day-to-day work life. Okay, the iliopsoas muscle is the primary muscle responsible for trigger point causing groin pain. So this much you remember. Pathology, what happens? So this is a problem in the motor end plate of a muscle. where there is a, it is a knot type of formation. So problem, abnormal motor end plate. So what happens? Spontaneous electrical activity starts there. So this spontaneous electrical activity, what it causes? So sarcoplasmic retinaculum, it becomes contracted. Continuous sarcoplasmic retinaculum calcium release, and ultimately it is a hypercontracture. Muscle remains contracted for a long time, uh, consistent with continuous sarcoplasmic retinaculum calcium release. Okay, secondary to neural activation and action potential generation. So just remember that spontaneous electrical activity will come from a knot-like structure in the muscle. That's it. So condition like fibromyalgia, arthritis, nerve entrapment, or herniated disc may mimic the myofascial pain syndrome. So these are DD. You have to examine and find some negative points that, of course, it is not that not the case of fibromyalgia. So, and this is the case of myofascial pain syndrome. So you may go for X-ray, MRI to rule out other diseases. USG elastography, these are experimental investigations. Nobody does in that way. But with USG elastography, you can see that muscle, how much it is. It is actually in liver disease, they do the fibroscan to see the fibrosis amount. So this is the similar thing to see that how much elasticity of that muscle is there. So experimental studies are there. If elasticity is lost, then myofascial triggers, or say trigger points are generated more. EMG of trigger point. So this is also experimental. You cannot order in your patient that go and do an EMG of the trigger point. So this is an experimental thing. It shows the spontaneous EMG activity. Okay. Then trigger point injection is the treatment. So you can see some, before trigger point injection, there are multiple treatments. As I told you that this is treated by different specialties. So if a patient goes to the physiotherapy, then he will go for UST first. Okay, ultrasonic therapy. This is if patient goes to a say occupational therapy, they will go for a manipulation. This one manual therapy. This is like spray and stretch. This is also physiotherapy they practice. And if they come to us, then we will of course go for trigger point injection. But remember, trigger any intervention should be followed. Should be preceded by the simple oral tablets or pharmacotherapy. And if that doesn't work, then only go for intervention. Trigger point injections are therapeutic modality in symptomatic patients. Really, if you search the trigger point correctly, then, and remember, while searching, search at the first time. It is not that now you pinpoint and you do not do any marking or anything, and then you clean that area. After that, again you are coming and pressing, you may not get that 10 trigger point, because with your pressing also that trigger point becomes all right for some time. It will come back again, but for some time you may not be able to find it. So always while pressing, first time only you mark that area, that this is the trigger point, I will inject here. Okay, so trigger point injections are therapeutic modality, but of course it is a short-term modality. Patient, if it is related to his workplace or work habit, then patient has to change that part. All alongside muscle relaxants and other medications aimed at decreasing pain in the musculoskeletal system. So some muscle relaxants are also given. So basis of trigger point injection, what it does. So there are multiple theories what it does. So mainly it improves perfusion. With the needle going inside, it improves the perfusion there. ATP replenishment to release the actin myosin chains. So there will be a bleeding, there will be small bleeding, so ATP will come and it removes the metabolic waste also. Okay, so ultimately it is it remains in a contracted state, so that fibers of muscle becomes ischemic. So as soon as you puncture, blood will come and that ischemia will go. So that is the main thing. Contraindication, of course, while in the mainly in the occipital area. So it has been seen multiple times in many patients that area their patient can have a open skull defect, or at least small defect can be there. So if you take a long needle, I mean even 2-3 centimeter needle also in the sub-occipital area, it is a dangerous area. It can go inside. So just keep that in mind. Otherwise, the same thing, patient on anticoagulation or pregnancy or difficult anatomical landmarks. So in these areas, these things we should keep in mind. Technique, always it is at the 90-degree. Earlier, it was told that a 90-degree angulation directly we can enter, but nowadays it is said that 30-degree angle into the trigger point and rhythmically continue needling the area by repeatedly inserting and retracting the needle. So multiple times you hold the if you can palpate the knot, you hold it between 2 fingers and then puncture in the knot multiple times. That is the main issue, main technique. Only thing is that in trigger point injection, we inject local anesthetic also. And if you do not inject local anesthetic, only hit by needle, that we will say that that is dry needling. Okay, so 2 techniques are usually done as a treatment. Complication reported, nothing as such, only allergic reaction to anesthetic agent can happen, but usually trigger point is very safe. One thing I will say, which I also saw, that don't think that it is only like IM injection, so nothing will happen. Patient can have vagovagal effect, patient may fall down. So it is always better you give injection when patient is sitting on a couch. If patient feels dizzy, patient can lie down. Okay. So there are multiple treatment modalities in myofascial pain syndrome. Apart from trigger point injection, if that doesn't work, like say botulinum injection and all. So this is botulinum toxin injection, and so these are in recalcitrant cases where it is not getting treated. Dextrose injection in chronic myofascial pain syndrome. So nowadays there is a new thinking that it is not only the muscle knot in the muscle, it is the fascial layer between the muscles which is causing the fasciopathy. So you can do a hydrodilatation in the fascia. Okay, pain from layers. So different superficial fascia, deep fascia, muscle, all can be painful. It is not that only muscle is painful and superficial and deep fascia doesn't have a role. So that's why in upper back 5-in-1 injection, one new injection is usually, and nowadays it is practiced. So what it does hydrodissection at 2 planes and hydrodilatation of 2 nerves. So 2 planes, 2 nerves and 1 muscle. Okay, so 5 injections are given in this method. Okay, so the main summary is not only the muscle, maybe the fascia is also the source of pain. Dry needling, as I told you, though here the needle is acupuncture needle, but you can go for dry needling with a simple hour half-inch needle also. Though it is not done by pain physicians, it is usually done by physiotherapists or acupuncture specialists. Sometimes some pain physicians also do, but here dry needling means we are not injecting anything inside. Okay, so this works by increasing the increasing the power of descending inhibitory pathway, descending pain inhibition. Okay, so ultimately trigger point injection, what it does, normalize the abnormal end plate activity, which was giving the spontaneous EMG activation. disrupt the sustained contraction cycle, restore the local blood flow and oxygenation. The needle mechanically also it can disrupt the dysfunctional muscle fibers and motor end plate, and repeated positioning and fanning movements break up taut bands, allowing sarcomeres to return to resting length. Okay. So thanks. This much is myofascial pain syndrome. If you have any question, you can ask. Otherwise, last topic, Dr. Devjiti will say about something about fibromyalgia. Devjiti?
I think no questions is there. Any questions regarding the last two topics? No. So let's go for the last topic. So last topic today
Sir,
is
one
fibromyalgia.
question.
Yes.
One question, previous speaker.
Yes.
Sir, we were talking about 5-in-1 technique. So, two muscles, two nerves, two planes, two nerves. So it is
Yeah.
between which planes, sir?
Actually, this I always show during my thoracic spine, thorax ultrasound class. Okay, so but then also I will show, but then still in our upper back, no, there are 3 layers of muscle. First layer, most superficial, is trapezius. Below that, second layer. Second layer is made by levator. What is that? Levator?
Scapulae.
Levator scapulae.
Levator scapulae, rhomboid spinal,
Rhomboidus
rhomboid
major.
major. Okay, these three muscles. Second layer. Third layer is serratus posterior superior. So between 1 and 2, you can find one nerve, that is accessory nerve, spinal accessory. Between 2 and 3, you can find another nerve, that is the dorsal scapular nerve. So you go in these two planes. Okay, these two planes and 3 muscles. Yeah, these two planes means this nerve also, and muscles. One muscle is trapezius, another is levator scapulae, another is this one, rhomboid muscle. Yeah, yeah. Actually, yeah. These 3 are muscles and 2 are planes. Okay, this total 5. Yeah.
Thank you, sir.
Okay, so let's start the last topic, that is the fibromyalgia. Remember, this is again one of the most difficult topics like complex regional pain syndrome, because first of all the diagnosis is a little bit difficult. A number of cases people have not able to diagnose in past, so we can call like CRPS or fibromyalgia, these are diagnosis of exclusions. And this type of pain now coined by the IASP as the nociplastic pains. That means where we are not able to figure out the exact cause of this disease. So let's start with the history. Shondha, a 40-year female attending pain clinic with history of pain from scalp to toe for last 4 years. Sometimes pain is burning and cramping in nature. She gets tired easily and aches with any activity. Her sleeping is restless. She awakes tired and complains of loss of memory. Especially the recent loss of memory is usually complained by the patient. All our investigations reports are within normal limits. Basically, when we get this type of patients, the patients usually come with a big amount of files, because what happens, the patient is moving from one doctor to another, and depending on the specialty, the number of investigations commonly done, but still the patient is not finding a solution, and for which the patient is coming to a pain physician. So what fibromyalgia is? It's a complex and chronic condition with widespread muscle pain, with presence of trigger or tender points within the muscle tendon junction, and other symptoms exists like fatigue, anxiety, depression, sleep disturbance, and morning stiffness. Sometimes there could be paresthesias and headache as well. So it's a complex syndrome of symptoms. If you go to the epidemiology, it usually affects 2 to 4% of the populations and more common in females, and this condition is seldom curable, sometimes can be associated with the other disorders like rheumatoid arthritis, or sometimes can be associated with the systemic lupus erythematosus as well. Now, if you see the frequency of fibromyalgia symptoms as the diagnostic criteria, the pain is there, so 100% of the patient is having the muscular pain. Most of the patients, 96% having easy fatigability. Then most of the patients having insomnia, and insomnia is quite a common feature. Sometimes in pathophysiology it is said that it's a part of the pathophysiology of the disease also. It is found in 86% of the patients, followed by the joint pain, headache, restless leg, paresthesia, memory impairment, leg cramps, poor concentration, anxiety, and in 20% of the patients can also suffer from major depression. Now, if we see the diagnosis, previously this disease was not coined with any specific term. It was known as the chronic fatigue syndrome. Sometimes the patients, especially the female patients, report to psychiatrists with such a symptoms. The first diagnostic criteria for the fibromyalgia was established in 1990, and ACR, that is the American College of Rheumatology, proposed the first official diagnostic criteria for fibromyalgia, and it was diagnosed as a chronic widespread musculoskeletal pain for lasting for longer than 3 months, and pain should be present in all 4 quadrants of the body. In addition, axial cell turn should always be present involved, and there were 18 trigger or tender points defined in the body in different parts, and that should be palpable with at least 4 kg of pressure, which is equivalent to the blenching of the nail bed of the examiner. So it's an arbitrary term, but this was more or less used for a long period of time. But this type of diagnosis has a limitation, because every time the patient is not having similar kind of pain. Some patients are having a little more pain, sometimes they are less sensitive, so sometimes their pain is more and sometimes their pain is less. So if you put this criteria for those patients, sometimes the patient will be put into the condition of 11 out of 18 tender points are present. So sometimes some patients will always remain in a gray line. Sometimes they will be putting inside the fibromyalgia landmark and sometimes will be outside. So it is limited by the requirement of the performations of the tender point examinations. It is limited by the variations and poor reliability, because the 4 kg pressure, which is actually corresponds with the blenching of the thumb nail bed of the examiner, is also a very arbitrary term. So here there is reliability also poor in clinical practice. And the fibromyalgia is not only the symptoms of pain, rather than there are the other symptoms like easy fatigability, then memory loss. These are also present, but symptoms other than the pain is not considered in this definition. So this actually delay in diagnosis as well as in management, because in a number of cases you won't be able to diagnose it as a fibromyalgia patient. So the next modification came from the ACR and Euler, and that is in 2010, and then they provided a more practical screening tool that no longer relies on a tender point examination, and currently it classified 88.1% of the cases defined using the ACR 1990 criteria, and uses 2 special index. One is known as the widespread pain index and the other is the symptom severity scale. Remember that most part of the fibromyalgia diagnostic criteria by the ACR 2010 criteria are mostly patient applied. That means here the physician don't have a role, only in small part, that is having the patient evaluation. So 2 parts are there. One part is the widespread pain index and other is the symptom severity index. Widespread pain index is completely self-administered by the patient. Symptom severity index, first 3 part is the self-administered by the patient, and the next part is the part 2 is by physician evaluation. And definitely we require the further screening. As I have told, it's a diagnosis of the exclusion. So we have to rule out the other common conditions that may give rise to this type of conditions. Okay, so total body is divided into 19 parts, and you ask the patient to tick mark on which areas of the body you are having pain, and based on that you are calculating the widespread pain index. So basically among these 19 areas of the body, it can range between 0 to 19. So that's the part of the widespread pain index. And then we are having the symptom severity index part 1. In the symptom severity index part 1, 3 symptoms are given highest importance in fibromyalgia diagnosis. One is the fatigue, number 2 it is the unrefreshed awakening, and third one is the cognitive symptoms. So they are also given 0 to 3 marks for each symptom. 0 stands for no problem, 1 for mild, 2 for moderate, and 3 for severe impairment. So based on it, the part 2A score can be from 0 to 9, but it has to be added with the part 2B score, which is actually a physician administered score. So what is there in the part 2b? Other symptoms other than those in the part 2a are considered the part 2b, and this is having a number of symptoms, and sometimes it is difficult for the patient to administer by self. That is why this part is actually the physician administered symptoms. And now physician takes the history, and based on the history he puts that if there are no symptoms, in between few symptoms, moderate symptoms, and great deal of symptoms. So in this part, even in the simplified screening tool of 2010 also some variability remains because of the examiner's variations. Okay, now there are three criteria needs to be fulfilled. First, duration of symptoms, it should be more than 3 months. There should not be any underlying disease describing these symptoms, and medication received in past months, because that can actually affect or change the symptom severity index. And if we found the widespread pain index more than 7 and symptom severity score more than 5, that means 9 plus 3, so altogether it will be out of 12, that should be 5. So if they meets the criteria of widespread pain index of more than 7 and symptom severity index more than, they are not more than, they are more than equal to, so basically widespread pain index should be more than equal to 7 and symptom severity index equal to more than equal to 5, or widespread pain index is less, like 3 to 6, and the symptom severity score is more, that is more than 9. In those conditions also we will take the patient as a fibromyalgia patient, and symptoms has to be present at the similar level for past 3 months, and the patient does not have any disorder to otherwise explain the pain. So if all three criteria are met, then we clinically can diagnose the patient as the fibromyalgia, but for which there are certain recommended tests like the CBC, CRPS, CPK, ESR, LFT, TFT, and in ideal fibromyalgia cases all should be normal. So that was the part by the SCR. Now there are few proposals post 2010 at number 1 Wolfe et al, because there are few shortcomings that has been seen for this criteria. Number 1, the widespread pain. So as in the, you see in the second part, that is the, if the widespread pain index is only 3 and symptom severity score is more than 9 or equal to 9, then also it should be considered as a part of fibromyalgia. So in this patient, sometimes some localized pain also came into a criteria of the fibromyalgia. So they fall, and then this modification was done, and there are quadrants divided. Okay, so left upper region, right upper region, axial region, right lower region, left region. So now this 0 to 19 now divided into groups, so that here now should be at least 4 region out of 5 involved. So that was the modification in 2016 by Wolfe et al to make the widespread pain index correct, because in previous areas just a hand pain or just a lower limb pain, so that can, or just some axial pain, okay, that can go into the fibromyalgia, so that should not happen. And next change happened in the symptom severity score modification, because in the third part of the self-administered part, so sorry, the patient physician administered part, to standardize it and to make it patient to the whole chart patient applicable, they have put 3 important criteria into part 2b, where they have put scores for the headache, pain and cramps in the lower abdomen or depressive symptoms, and they have given 1 point each to make it 12. So that modification change was done, but remember these modifications were suggested by the researchers, but ACR still holds the same criteria, that is the 2010 criteria. Now coming to the pathophysiology of FMS. Truly speaking, pathophysiology of FMS or fibromyalgia is not clear. Certain clinical biochemical findings are well documented. There are several hypotheses based on these findings, some of which are well accepted, some of which are questioned. Now, for example, these are the documented findings. It may develop after hemorrhagic trauma. Substance P in CSF may be 3 times higher than in fibromyalgia patients. There is possibility of the low serotonin level in platelets and in central nervous system. There is low level of the ATPs in RBC and the trigger points. There is dysfunction of the hypothalamo-pituitary adrenal axis. that is found to be patients that are found to have low growth hormone. Nerve growth factor is found 4 times higher in the CSF. Strong familial pattern is also noticed, and females are more affected, and non-restorative deep sleep is also observed. So there are explanations of all, like in the non-restorative deep sleep, it has been said that the growth hormone which in childhood actually helps for our growth, in adulthood that works as a healing hormone for us. But what happens during the deep sleep, these hormones are secreted, and due to lack of growth hormone, that is causing the damage and repair of the tissues are hampered. So for all the causes there are some explanations, but that are big explanations, and if you go it will be a too detailed class, and that much is not required for a clinician. So whatever the cause is, the key is central sensitization. We do not know the exact biomechanical cause, what is causing the all the nervous system to be more sensitized. I always explain to my patients like this, that whenever you get a pressure on your hand, so initially you feel as a touch. Now if you press it more, it will become a pressure. If you press it further, it will become a pain. But what happens in those patients, these thresholds are all had. So ultimately what happens, when the patient usually lies down in a bed, the portion of the patient's body due to gravity in contact with the bed, that becomes painful, because instead of pressure sense, it is actually sensing a pain sense. So basically, because of the central sensitization, for an unknown cause, the whole nervous system becomes hyperactive, and they are actually become more pain sensitive, and that is the reason behind the causes. Now coming to the treatment option. Now, so here in the treatment, we are having certain drugs that has been found to be helpful for to diminish the pain. We have the tramadol, paracetamol, and NSAIDs. We have to use them judicially according to their individual guidelines. Among the antidepressants, it has been found that the TCS, SNRIs, and SSRIs, as well as the noradrenaline enhanced SRIs, basically that is the milnacipran. So that drug is also very effective. Also the anticonvulsant group like pregabalin and gabapentin, they are also useful. Now if you go for the FDA approved medications for fibromyalgia, it was for long only 3: pregabalin, which was been approved in 2007, then duloxetine in 2008, then milnacipran in 2009, and after that there is a long gap. And after this long gap, I already told, this 15th August, the 4th drug was approved by the FDA, and that is the cyclobenzaprine, and in the oral, that is the in-mouth sublingual preparation, which actually is also found to be effective in different studies in fibromyalgia. That's why FDA approved it. So basically it's the 4th drug approved by FDA, but till now it is not available. So whatever available, let me talk about that. First of all, pregabalin, it reduces pain and improves the daily functions in some patients of fibromyalgia, and practically in a number of patients this is the mainstay of treatment for the patients, and it can cause a pain reduction of 30% and very small effect on the fatigue and small effect on the sleep as well. And most common side effect is the mild to moderate dizziness, sleepiness, blurred vision, weight gain. Sometimes some patients complain of peripheral edemas also. Sometimes in a rare patient that it can cause the dry mouth, and sometimes swelling of the hands and feet. So be careful whenever you start pregabalin, start with a lower dose, because if you start with a higher dose, the problem will come, the patient will be too sedated. So usually the patient do not want to be. So 2 tips: 1, start with a lower dose. Now even 25 milligram dose is available. So you start with the 25 milligram at 7 o'clock in the evening, so that till morning the sleepiness of the patients is reduced. Or you can start with 50 milligram tablet and then gradually increase up to 600 milligram maximum you can go. But for Indian patients, the usually required dose is 75 to 150 milligram. Rarely we have to go up to 300 milligram. Gabapentin is a previous congener of the previous drug of the pregabalin, which is having almost similar effect, except for that its absorption profile is not same. It is a little erratically absorbed after oral administration, and the sleepiness is more in some patients. So if the patient is having sleep disturbance, instead of pregabalin, you can start with the gabapentin, and usual starting dose is 300 milligram, then gradually increased up to 1200 milligram. Though theoretically to up to 2400 milligram it is written in books, but in most of the patients we have to limit the dose up to 900 to 1200 milligram. But even in some patients who feel you are feeling very sensitive, we can start with as small dose as 100 milligram that is available, and then gradually increase up to once in every 3 days, and then go up to the level of 900 milligram, or the pain relief is there. Then coming to the amitriptyline, age-old medication, not approved by the FDA for the fibromyalgia, but it has been found to have a good effect on fibromyalgia patient. There is 30% pain reduction, moderate effect on the sleep, and the small effect on the fatigue. And amitriptyline in aged patients, sometimes it can cause problem like sinus tachycardia, or it can cause, in cardiac patients it might cause problem, and in some patients with the BHP it can cause problem with the urine, passing of the urine. So these are the problems remaining with the amitriptyline. So you have to give judiciously and depending on the patient, definitely. Among the SNRIs, duloxetine and milnacipran, which is actually not there's a difference in between the reuptake inhibition of the serotonin and norepinephrine. So basically in duloxetine, it is 5 times more potent on serotonin than norepinephrine, whereas the milnacipran, it is quite more potent in norepinephrine than serotonin. So basically duloxetine is the selective serotonin norepinephrine reuptake inhibition. Here serotonin comes first, and the other one, it is the serotonin enhancing norepinephrine reuptake inhibitor. So basically here it is more potent on norepinephrine. Though milnacipran was used long, I have also used milnacipran, then levomilnacipran came, but nowadays it is not available. So what we are mainly among the approved drugs, we have to go for either duloxetine or pregabalin mostly. Now here is the recommendation by the EULAR. So basically first you take the history, physical examination, do the diagnosis on fibromyalgia, then most important the patient education and the information and sheet and the physical therapy. If there is insufficient effect, then reassess the patient, and then you can think of the other modalities. If there is more pain related depression, anxiety, and sometimes there is passive or active coping, so you have to go for the psychological therapy, mainly the cognitive behavioral therapy, and in some cases in severe depression, anxiety, you have to go for the psychopharmacological management. If there is severe pain with the sleep disturbance, go for the initial pharmacotherapy. For the severe pain, go for the duloxetine, pregabalin, tramadol in combination with the paracetamol. Remember, here there is a catch. In between this duloxetine and tramadol, you should not be using both in a very high level, because there is a rare but devastating situation is there, that is known as the serotonin syndrome, that might happen. So be careful in using both together at a high dose, but at low dose it doesn't cause much problem. So severe sleep problems like the low dose amitriptyline, cyclobenzaprine, or pregabalin at night. So basically oral cyclobenzaprine was used as an off-label drug, but now it came as a oral lozenge type thing, and that is as a FDA approved indication. If there is severe disability, then you have to go for the multimodal rehabilitation program for that patient. So that was all regarding the fibromyalgia. So if you have any question, I'll be answering. But before that, let me show you. This is one of the blog posts I posted and shared to you as well. So basically, this is the role of the newer drug, which is actually named in the name of the Tonmya, and that is basically and cyclobenzaprine hydrochloride sublingual tablets, where it has been shown some benefits. So whatever today I know about it is theoretically only, but definitely when it comes to India, we'll use it and we'll uh, inform in the courses what are the responses and how we are getting it with the patients as well. So please read this article that is in the Asian Pain Anatomy website. Any questions? Oh, another thing that I forgot to mention about the ketamine, because previously we used to say there is one condition when nothing is working, then we used to try a thing that is known as the systemic desensitization. Systemic desensitization is basically injectable ketamine therapy for successive 3-4 days. Okay, and in a recent Cochrane review, it has been shown, that is that the review extract will also file in our website, and that says that here it doesn't have any beneficial role. If you compare with the side effects of the IV ketamine and you see the benefits in chronic pain, it doesn't actually rationate to use a chronic ketamine in a chronic pain patient. So read that one also. If you want, I can show you that as well. Okay, so this is the, so you come to the Asian Pain Academy site, so you come down and this is the article. Okay, ketamine in the chronic pain, which is the latest Cochrane review reveals. Okay, so you read this article as well. So it will be an updating thing for you. So any questions? I think today we have taken a little more. Anyone having any questions?
I think no more question. We have taken a bit more time.
Okay, so let us go for the next day. Okay. Chinmaya, are you missing anything? No. It is already 8, so I think
Yeah,
we've
yeah.
taken too much. So let's move. Okay, so let's
Okay.
end today.
Okay. Good night. Good night.
Good night, all.
Good night, sir. Good night, sir.